Now, I take great privilege in inviting Colonel Dr. Mahendra Sir to formally welcome the distinguished speakers and delegates.
Distinguished speakers, delegates, guests, faculty, and dear students. Enough has been said in the morning session about AI, behavioral science, behavioral change, and all. So now, let us hear our distinguished speaker on how we can transform our community health care through AI and behavioral change integration. Okay, generally we see that whatever improvement are required to be there, it is services are there, but failures are also there, and how we can change those failures into success so that we can improve and we can achieve our community health in a better way. I was just wondering, using intelligence in your community health, how it is important. Even the word artificial, when it gets integrated with intelligence, it gets its importance. Okay, but when this artificial word is linked with anything else, then you don't give much importance. In fact, one of the global conference which is going on in Delhi, I was just hearing one of the eminent speaker. He was also mentioning that why we call it artificial intelligence, why not to call it augmented additional information. So that kind of additional information we are going to have now in track 1. And in track 1, as you all know, we have got eminent speaker, Mr. Parasnath, who is Director Program Antara Foundation. And we have Dr. Ashwani Agrawal, Director PwC India. And we have Dr. Vivek S. Agrawal, who is founder Center of Development Communication India, and Mr. Hemant Bhatnagar, who is Facility Director Narayana Health. So I'll request all the eminent speakers to join me on the stage, please. And Dr. Vasha Tanu. Thank you. Yeah. So over to you, anchors.
Thank you, sir. Let us begin by welcoming our distinguished guest.
It is an honor to introduce Mr. Parasnath Sid Sir, Director at the Antara Foundation.
Mr. Sid brings over 17 years of extensive experience across public health, nutrition, humanitarian response, and disaster risk reduction. His work is deeply rooted in strengthening health system through policy-aligned program design and the use of data and digital innovation at scale.
May I now request Mr. Parasnath Singh Sir to kindly address the audience.
Yeah. Very good morning, all. आज का जो कॉन्फ्रेंस है, ये कॉन्फ्रेंस इस टाइम के अनुसार, बिकॉज देयर इज ए लॉट्स ऑफ द एक्सपेरिमेंटेशन हैपनिंग अराउंड द वर्ल्ड बाय यूजिंग द आर्टिफिशियल इंटेलिजेंस, और स्पेशली जो हेल्थ केयर को लेके हैं, और बहुत सारे एक्सपेरिमेंट अक्रॉस द इंडिया भी हो रहे हैं बट ग्लोबली भी हो रहे हैं. एंड आई आल्सो वुड लाइक टू शेयर द टू ऑफ द एक्सपेरिमेंट्स विच करंटली फिट विद द गवर्नमेंट हेल्थ सिस्टम एक्चुअली. तो मैं इसके बारे में चर्चा करूँगा. एंड आई एम पारस फ्रॉम द अंतरा फाउंडेशन. और अंतरा फाउंडेशन बेसिकली जो राजस्थान से अंतरा फाउंडेशन का जर्नी 2015 में स्टार्ट हुआ था, और हम 2019 में यहाँ राजस्थान से मूव ऑन हुए थे. बट आई जस्ट वांट टू टेल द वन स्टोरी अबाउट राजस्थान, दैट वी एबल टू पायलट सम good solution with the frontline health worker, especially ASA, Anganwadi and ANM, and we able to roll out our solution across the Rajasthan in all villages across the 46,000 villages. And after successfully rolling out that intervention, we moved out from the Rajasthan, but the memory and legacy remain always, and it's so nice to be in Jaipur after long days. And I going to talk about the two of the our intervention, especially the AI driven intervention. So especially जो हमारा फोकस अंतरा फाउंडेशन का अभी फ़िलहाल जो सबसे ज़्यादा रिमोट या जो लास्ट माइल जो कम्युनिटीज़ है, वहाँ पर हमारा ज़्यादा फोकस है, और क्वालिटी हेल्थ केयर को लेके ज़्यादा फोकस है. तो इसी थीम पे हम ज़्यादा फोकस करते हैं. ये कुछ फुटप्रिंट है ऑर्गेनाइजेशन का. तो स्पेशली अभी हम फ़िलहाल मध्य प्रदेश में ज़्यादा एक्टिव हैं, और मध्य प्रदेश में अराउंड 80 लाख पॉपुलेशन को अभी फ़िलहाल हम डिफरेंट इंटरवेंशन के थ्रू कवर कर रहे हैं, थ्रू द सपोर्ट ऑफ द हेल्थ डिपार्टमेंट एंड आल्सो डिपार्टमेंट ऑफ द वुमेन एंड चाइल्ड डेवलपमेंट. एज यू नो दैट दीज 3 हेल्थ वर्कर हम सभी को हमारे जन्म से पहले से जानते हैं. ये इनके बारे में सबसे एक यूनिक चीज़ है, जब हम बोर्न नहीं होते हैं इनके रिकॉर्ड में हमारे बारे में डिटेल होती है. इनके आशा है, आशा की डायरी में रिकॉर्ड मिलेगा हमारे बारे में. आंगनबाड़ी वर्कर है तो वो भी हमारे बारे में प्रेगनेंसी टाइम से ही हमारे बारे में रिकॉर्ड रखेगी, और एएनएम भी वैसा करती है. तो आप सभी जानते हैं कि जितनी भी हमारे टाउन में या सेमी टाउन या अर्बन एरिया में आशा, आंगनबाड़ी, एएनएम रहती है, वो मोस्ट ऑफ हेल्थ वर्कर नो अस फ्रॉम द लाइक बर्थ टाइम और बिफोर द बर्थ टाइम. एंड हमारा भी जो सॉल्यूशन है अंतरा फाउंडेशन का, वो इन 3 हेल्थ वर्कर को इनेबल करने को लेके ही ज़्यादा हैं. और जो हम टेक्नोलॉजी सॉल्यूशन ड्रिवन जो एआई बेस्ड सॉल्यूशन है, वो भी इनको फोकस करके हमने डिज़ाइन किया है. So especially the one of the digital AI-based digital solution is the enabling the health worker with the right protocol on 24-hour requirement based. Especially the health worker can ask the question, they can read the content, they can watch the videos, they can listen the audios, and they also take the help for the troubleshooting on day-to-day basis. और इसके पीछे हमारा एक एक्सपीरियंस पिछले 10 और 11 ईयर का अंतरा फाउंडेशन में रहा है कि वी ट्रेंड द और लाइक 10,000 प्लस हेल्थ वर्कर across the Rajasthan and also currently in the Madhya Pradesh. And as per like 10 years of the experience, we realized that कि जो आर्टिफिशियल इंटेलिजेंस है, इसका जो यूसेज है वो फ्रंटलाइन वर्कर उनकी कैपेसिटी बिल्डिंग को लेके काफ़ी यूजफुल हो सकता है. और उसी पेडोलॉजी को हमने ध्यान में रखे एक्चुअली अभी एक्सपेरिमेंट हम कैपेसिटी बिल्डिंग को लेके कर रहे हैं, जो एआई ड्रिवन है. ये मैं यहाँ पर कुछ रिजल्ट भी बताना चाहता हूँ कि जो हमने 10 ईयर तक हेल्थ वर्कर की जो कैपेसिटी बिल्डिंग का काम किया है, तो एक सभी जगह एक अच्छा पैटर्न देखने को मिला है कि यदि राइट ट्रेनिंग, राइट हैंड होल्डिंग और सही समय नजिंग होता है नॉलेज को लेके, तो ऑब्वियसली वो ट्रांसलेशन है नॉलेज का, वो स्किल में भी कन्वर्ट होता है. एज यू सीइंग हियर दैट कि जितने भी जो फ्रंटलाइन वर्कर जिनको हमने ट्रेनिंग किया है, उनका जो नॉलेज लेवल है और डेफिनेटली काफ़ी अच्छा ट्रांसफॉर्मेशन हुआ है. So in context of this story, last year we set up the digital health system and function in the organization, and we started to building the team to work on the digital solution, especially in the Madhya Pradesh and some other state. तो डिजिटल सॉल्यूशन का एक सबसे बड़ा जो हम पहला जो सॉल्यूशन मैं बताना चाह रहा हूँ, उसका जो सबसे ज़्यादा जो विशेष फीचर है वो ये है कि जितने भी मटेरियल जो डिज़ाइन किए गए हैं और डिजिटल मॉड्यूल में कन्वर्ट किए गए हैं वो एज पर द गवर्नमेंट प्रोटोकॉल गाइडलाइन और पॉलिसी जो प्रोवाइड किए गए हैं उसके बेसिस पे हैं. तो कुछ भी उसमें ऐसा नहीं है कि आउटर वर्ल्ड जितना भी लाइक कि गूगल पे अवेलेबल है या ओपन जो इन्फॉर्मेशन अवेलेबल है उसके थ्रू एएनएम आशा आंगनबाड़ी का टीचिंग होता है. This is purely based on the government guideline, protocol, and policies. So especially the Anmol Didi right now we implementing in the Madhya Pradesh with the, around 3,000 health worker, and this is in right now in the experimental phase, but there's a huge learning from this solution, and this solution got the huge acknowledgement across the different institution. So this is solution is the chatbot based solution, और ये जो चैटबॉट जो सॉल्यूशन है वो AAA के लर्निंग के बेसिस पे डिज़ाइन किया गया है. और अभी फ़िलहाल जो MNCHN थीम्स हैं, स्पेशली जो मैटरनल, नियोनेटल, चाइल्ड हेल्थ एंड न्यूट्रिशन थीम्स है, उनके बेसिस पे इसको डिज़ाइन किया गया है. तो यहाँ पर आप कुछ फीचर्स देख पा रहे हैं कि ओबियसली एज आई स्टेटेड दैट कि ये गाइडलाइन बेस्ड ही आंसर करता है, और जो इसमें माइक्रो लेवल के कुछ लर्निंग के वीडियो है वो इंट्रोड्यूस किए गए हैं ताकि हेल्थ वर्कर है वो देख के सुन के भी समझ सकें. और उसके बाद साथ में हमने उसको थोड़ा इंटरेक्टिव बनाने के लिए गेमिफाइड भी किया है सॉल्यूशन को, ताकि एक इंटरेक्टिव प्रोसेस हेल्थ वर्कर के साथ में रहे. एंड देन वी आल्सो लाइक डिज़ाइन द सम पीरियोडिक असेसमेंट फीचर्स आल्सो इन दिस सॉल्यूशन. सो फॉर एग्जांपल एक एएनएम है, मान लीजिए उसने होम बेस्ड नियोनेटल केयर के बारे में सीखा है, एक नए मॉड्यूल के बारे में सीखा है, तो इन एंड दे कैन आंसर द सर्टेन क्वेश्चन आल्सो. सो दिस विल हेल्प टू असेस द नॉलेज ऑफ द हेल्थ वर्कर आल्सो. This also like support in the MNCHN related programs and campaigns also, like you all heard Dastak program, Poshan Abhiyan and other program also, तो उसमें भी काफ़ी help करता है. And also this like design in that way that कि जो learning gaps है frontline worker में वो भी अच्छे से monitor हो सकें और उसके ऊपर कुछ practical solution design किए जा सकें. So जो मैं themes का बात कर रहा था, especially we included the low birth weight module in this chatbot, and also home-based postnatal care, then pregnancy-induced hypertension, then severe anemia during the pregnancy, and we also included some job aids as per the like a given job chart. So this Anmol Didi, the recognition we get very recently by the Honorable Prime Minister in Madhya Pradesh also during his visit. And recently we also get the National Innovation Award during the Infuse Summit in the NIN, National Institute of Nutrition in the Hyderabad. So now talking about like some initial result, like how the 2000 plus health worker used this solution and what the finding we are getting actually. So the one thing is that जो initially जो 3000 plus health worker को हमने enroll किया था उसमें लगभग 2000 हेल्थ वर्कर है वो एक चैटबॉट को यूज़ करना स्टार्ट कर दिए हैं. इसमें हमने एक चीज़ ज़रूर ध्यान में रखा है कि वी नॉट पुश टू यूज़ दिस सॉल्यूशन एक्चुअली. They just like if whenever they feel that the frontline worker need some new information or they need the for example troubleshooting nudging actually, so they ask the question by the voice note or typing the like in question in the any language also. So the chatbot can provide the very like personalized learning module to them. The one more part जो इसमें हमारी लर्निंग में जो सबसे बड़ी आई है कि 85% जो हेल्थ वर्कर है, एवन उससे ज़्यादा हेल्थ वर्कर, दे रियलाइज दैट दिस इज़ वेरी हेल्पफुल टूल, और इस तरह का टूल है, हमें बेसिकली इसमें मॉड्यूल का एक्सपेंशन भी करना चाहिए. व्हाट दिस मीन कि एमएनसीएचएन थीम के अलावा जो बाकी थीम्स है, फॉर एग्जांपल फैमिली प्लानिंग है, या एनसीडी है, या फिर जो क्लिनिकल स्क्रीनिंग है, तो उसके जो मॉड्यूल है या जो पेडोलॉजी है वो भी इस चैटबॉट में होनी चाहिए. सो यहाँ पर आप देख रहे हैं कि सबसे ज़्यादा जो क्वेश्चन ट्रिपल के द्वारा पूछा जाता है वो कौन से क्वेश्चन पूछे जाते हैं. तो सबसे पहले आप देख रहे हैं कि चाइल्ड हेल्थ को लेके हेल्थ वर्कर हैं वो सबसे ज़्यादा क्वेश्चन पूछते हैं, उसके बारे में सबसे ज़्यादा जानकारी चाहते हैं. फिर आप देख रहे हैं कि एनसी केयर को लेके, और देन न्यूट्रिशन एंड एनीमिया, देन प्रोग्रामेटिक इम्यूनाइजेशन, एंड देन आल्सो दे लाइक लुकिंग सम सॉल्यूशन फॉर द डिजिटल एंड एडमाइन रिलेटेड इश्यूज आल्सो. यू नो दैट अभी जो नेशनल डिजिटल हेल्थ मिशन है उसमें आबा आईडी लेके भी एक कॉन्सेप्ट आया है, और उसका पूरा जो बर्डन है, वर्क बर्डन, वो आपकी एएनएम, आशा और आंगनबाड़ी वर्कर के ऊपर होता है. और रूरल में अभी भी बिकॉज देयर इज लॉट्स ऑफ द टेक्निकल ग्लिचेज, इंटरनेट एक्सेस नहीं होता है, एंड्रॉयड मोबाइल अच्छे से वर्क नहीं करते हैं, हेल्थ वर्कर को इतना अच्छा प्रैक्टिस या नॉलेज नहीं होता है कि कैसे एक प्रोफाइल क्रिएट की जाए, आईडी कैसे बनाई जाए. तो ये सिस्टम हमें ये भी हेल्प कर रहा है कि एग्जैक्टली ट्रिपल की नीड क्या है लास्ट माइल में, क्योंकि ये सबसे नज़दीक है आपके बेनिफिशरीज की. ये तीनों वर्कर है जो सबसे नज़दीक है उनके, और उनके जो डे टू डे जो समस्याएं आती है उसका क्वेश्चन इस चैटबॉट में पूछते हैं. तो आप नीचे वाली जो भी थीम देख रहे हैं वो हमारे अभी फ़िलहाल मॉड्यूल में है नहीं, एलएमएस में डाला नहीं है, बट दे आस्किंग द क्वेश्चन एक्चुअली, राइट. एंड दिस हेल्पिंग अस टू लाइक थिंक इन न्यू डायरेक्शन आल्सो कि एग्जैक्टली हमें ट्रिपल को और क्या सपोर्ट देना चाहिए और कौन सी इंफॉर्मेशन के साथ इनेबल करना चाहिए. तो यहाँ पर भी आप देख रहे हैं कि एग्जैक्टली जो सबसे ज़्यादा जो यूज़ होता है वो स्पेशली जो डिसीजन सपोर्ट रिलेटेड क्वेश्चन है, वो क्वेश्चन है वो ट्रिपल सबसे ज़्यादा पूछती है. उसको लेके भी सबसे ज़्यादा वो ग्राउंड पे प्रैक्टिस भी करती है और उनको हेल्प का नीड भी होता है. फिर आप देख रहे हैं कि कुछ क्वेश्चन कैलकुलेशन रिलेटेड होते हैं. जैसे मैं आपको एग्जांपल देता हूँ कि 1000 पॉपुलेशन पे कितनी प्रेग्नेंट होनी चाहिए, राइट, या 1000 की पॉपुलेशन में कितने बच्चे 0 to 5 ईयर के होने चाहिए, या इम्यूनाइजेशन का टारगेट क्या होना चाहिए. तो इस तरह के क्वेश्चन भी बहुत आते हैं बिकॉज हेल्थ सिस्टम में ऑल यू नो दैट की बहुत ही टारगेट ड्रिवन प्रोसेस भी होता है, और उनको इस तरह की इन्फॉर्मेशन की बहुत ज़्यादा नीड होती है. फिर आप देख रहे हैं कि कुछ ऐसे भी हैं जो लर्निंग स्पेशली जो जानना चाहते हैं कि कॉन्सेप्चुअल लर्निंग या कन्फर्मेशन, राइट, कि मैं जो काम कर रही हूँ या एक्ट करने वाली हूँ वो एक्ट सही है या नहीं है, उसमें उनको कॉन्फिडेंस भी चाहिए, तो उसके लिए सवाल भी वो करते हैं. So here just for the information like considering the time also just highlighting here कि जो core एमएनसीएचएन जो क्लिनिकल जो कंपोनेंट है उसको ट्रिपल हैं वो सबसे ज़्यादा उन मॉड्यूल को यूज़ करती है. आप देख रहे हैं कि करीब 60 to 70% जो क्वेश्चंस हैं वो इस कंपोनेंट के रिलेटेड ही आते हैं, इस थीम रिलेटेड ही आते हैं. देन कुछ नॉन एमएनसीएचएन क्लिनिकल, प्रोग्रामेटिक, एंड देन कुछ नॉन एमएनसीएचएन एरियाज को लेके भी वो क्वेश्चन पूछते हैं. सो यहाँ पर आप देख रहे हैं कि जब हमने ये पायलट सितंबर 2025 में शुरू किया था तो इनिशियली वी ऑल वरीड एवन विद द हेल्थ डिपार्टमेंट आल्सो कि हेल्थ वर्कर है वो यूज़ कर पाएंगी या नहीं कर पाएंगे इस चैटबॉट को, कितना इफ़ेक्टिव होगा. लेकिन टाइम के साथ आप देख रहे हैं कि इन दोनों लाइन में काफ़ी गैप आने लगा है. So this means कि now health worker started using this solution more actually. They asking very frequent question on day-to-day basis, and we just like assuming that in next couple of month this line जो gap है वो और ज़्यादा हो जाएगा. यहाँ पर हमने थोड़ा ब्रेक डाउन किया टॉपिक वाइज भी कि किस तरह के टॉपिक के ऊपर क्वेश्चन ज़्यादा आते हैं. तो आप जो 2000 हेल्थ वर्कर का जो फाइंडिंग यहाँ पर देख रहे हैं, तो सबसे ज़्यादा डिलीवरी के बाद आहार क्या होना चाहिए, एनीमिया रिलेटेड क्वेश्चन आते हैं। ट्रिपल ए बैठक जो मैं बता रहा था थोड़ी देर पहले कि हमने एक फ्लैगशिप इंटरवेंशन राजस्थान में ट्राई आउट किया था और फिर पूरे राजस्थान में स्केल किया था, एंड नाउ वी स्केल्ड इन द 100 ब्लॉक्स ऑफ द मध्य प्रदेश। तो इससे रिलेटेड सवाल भी बहुत आते हैं, और फिर आप देख रहे हैं कि कुछ बाकी और थीम्स है उनके बारे में क्वेश्चन है वो कंटिन्यूसली पूछते हैं। सो हम क्यों स्पेशली इसमें बिलीव करते हैं, क्योंकि एक तो ये है कि ये बहुत सारे हेल्थ वर्कर के द्वारा ही टेस्टेड सॉल्यूशन है, और हमें पूरा कॉन्फिडेंस है उनके कॉन्फिडेंस के ऊपर कि वो क्या लर्न कर रहे हैं, चैटबॉट का इस्तेमाल कैसे कर रहे हैं, और वो कंटेंट उनके लिए किस तरह से काम आ रहा है। द वन मोर पार्ट, because we have also 10 years of the legacy to developing the different training pedagogy and material for the health worker, and वो learning जो हमारी इन हाउस टीम की जो learning है इस solution को डिज़ाइन करने में बहुत काम आ रहा है। और आज के दिन भी हमारे जो 130 प्लस जो टेक्निकल ऑफिसर है वो ऑन ग्राउंड 20,000 जो हेल्थ वर्कर है उनके साथ डे टू डे काम करते हैं। तो उनका जो फीडबैक सिस्टम है वो हमें बहुत ज़्यादा कॉन्फिडेंस दे रहे हैं कि इस तरह का जो बिहेवियरल और जो प्रैक्टिकल जो लर्निंग सॉल्यूशन है वो हेल्थ वर्कर के लिए बहुत कामयाब हो सकता है। The way forward, we thinking that recently in recent conversation with the national government and Madhya Pradesh state, we looking to roll out this initiative across the 2 lakh frontline health worker in the Madhya Pradesh. So that's the broad plan for this year, and we also like exploring some expansion scope in the other state also. So the communication right now going with the Odisha government and Meghalaya government also, but we looking forward to like design the end-to-end chatbot solution to enable the health frontline health workers, and also we want to expand this solution across the India. The second concept is about the Anungami. You know, all people know about the Anungami, right? The meaning of Anungami is like he follow something, right? ना? So ये अनुगामी स्पेशली आपने देखा होगा कि हेल्थ सिस्टम में बहुत सारी इमरजेंसी
for the outreach follow and वापस स्पेसिफिक फॉलो के लिए। तो स्पेशली जो ये रेफरल लूप है इसको क्लोज करने के लिए सॉल्यूशन डिजाइन किया गया है, और अभी फिलहाल जो हमने डिजाइन किया है वो जो न्यूनेट एट रिस्क जो न्यूनेट है ना उनके लिए डिजाइन किया है, बिकॉज यू नो दैट ऑडियो गई अभी भी अराउंड 30 to 32 न्यूनेट हजार की पॉपुलेशन पे हजार लाइव बर्थ पे खत्म हो जाते हैं, और यहाँ पर बहुत ज़्यादा नीड है रेफरल क्लोजर कम्युनिकेशन और नचिंग। तो इसी चीज को ध्यान में रखते हम अभी
फिलहाल पायलट कर रहे हैं मध्य प्रदेश के 2 डिस्ट्रिक्ट में हेल्थ डिपार्टमेंट के साथ में मिलके। सो आई क्विकली लाइक इज शोइंग दिस सॉल्यूशन आल्सो टू ऑल ऑफ यू। या डेफिनेटली आई जस्ट फिनिश अप इन द 2 minutes right yeah. So here we piloting with 1740 health worker, और यहाँ पर स्पेशली आप देख रहे हो कि एक आशा वर्कर को टाइमली कम्युनिकेशन कैसे मिले उनको घर पे जाने के लिए। यू नो दैट कि जितने भी जो न्यूनेट एट रिस्क बेबीज होते हैं आशा को 0 to 7 days में पहले 7 दिन घर जाना पड़ता है, फैसिलिटी फॉलोअप करवाने पड़ते हैं, और फिर 56 days तक भी उनका एक रूटीन विजिट घर पे होता है। तो यहाँ पर बहुत ही पर्सनलाइज्ड जो नजिंग मैसेज है वो हेल्थ वर्कर को जाते हैं, ताकि जिस दिन उनको घर जाना होता है वो जा पाएँ, और साथ में जो उनको एक्ट करना है, जो रिस्क आइडेंटिफाई करना है या स्क्रीनिंग करना है या डिसीजन मेकिंग करना है, वो सपोर्ट भी उनको मिल जाए। सो हियर जे लाइक ब्रॉड हाईलाइट इसका जो इनिशियल इम्प्रेशन है कि हेल्थ वर्कर को ये सॉल्यूशन काफ़ी ज़्यादा हेल्प कर रहा है टू nudge them but also take the right decision to refer at right facilities. So on this part right now we are working with the IIT Mumbai actually and we designing this solution. अब फिलहाल हम नियोनेट एट रिस्क जो बेबीज है उनके रेफरल क्लोजर को लेके सॉल्यूशन डिज़ाइन किया है, पायलट किया है, बट राइट नाउ वी प्लानिंग टू क्रिएट दिस सॉल्यूशन फॉर द pregnant women and also for the intrapartum beneficiaries, especially during the 48 hour of the window during the delivery time. So this is all about the two solution. If you have any question, can ask here. Yeah, okay, thank you so much, yes.
They are doing a wonderful job, no doubt. Because we have been visiting to the periphery, IIHMR Arogya Mandir and all, so we can see the results. How learning to the frontline workers and how they are taking care of high-risk cases at the periphery. It's a wonderful job, wonderful training, education to the frontline workers. So thank you for your talk.
Thank you, sir, for enriching this conference with your valuable insights.
Now, we are equally privileged to introduce our next distinguished speaker, Dr. Ashwini Agarwal, sir, Director at PwC India.
Dr. Ashwini Agarwal, sir, is a seasoned healthcare and life science professional, currently serving as Director, Health Industries Business Transformation at PwC India. He works closely with public and private sector stakeholders to advance healthcare system strengthening and strategic transformation across the ecosystem.
We warmly invite Dr. Ashwini Agarwal, sir, to share his insights with us.
Hi, good afternoon, everyone. So when I was invited for the session, Kirti was asking me, sir, can you send me a brief profile of yours? And I was like, कि आज भेजता हूँ, कल भेजता हूँ, परसों भेजता हूँ. She took the initiative and she drafted my profile using AI. And what she drafted me was better than what I had actually. So what you are seeing on the screen right now was not given by me actually, it was drafted by Kirti only. Yeah. So hi everyone, I am Ashwini. I work as a director in the PwC healthcare practice. By training, I'm a physician. I did my medical sciences. I practiced for a couple of years and have been the consulting for almost like 14, 15 years. In PwC, I lead the health system design portfolio and have been working with a couple of stakeholders over there. You can make out that I'm a management consultant because I have a PowerPoint presentation that I'm going to take you through that shortly. Yeah. So the topic that was given to me was the healthcare trends which are happening in the country right now. How the ecosystem is evolving, who are the new stakeholders, what are the drivers driving this particular change, what are the barriers, and more importantly, how we see the future evolving going forward. And this is particularly important for the students who are about to graduate or who are graduating next year, because these are the skills that you ought to acquire or at least be familiar with these trends, because this is going to determine to a certain extent your placements, your career professionals, your job choices, things like that. So maybe with that viewpoint, I'll take the presentation. So while I have been accustomed to public speaking a lot, I have been doing for multiple years, suddenly public speaking has become a lot more dangerous now. So if I say something wrong, please don't troll me on the social media. Okay. So when we talk about the trends which are happening in the country right now, my strong request is you look at from an overall Indian perspective, what is happening in India right now. And India, the country that we see right now, is very different from the country that we saw in the previous century. Today, we are the world's 4th largest economy. That's no joke by any mechanisms. It's more than a $4 trillion economy. On a per capita basis, we are still to breach that lower middle income mark, but by every other parameter, we are right up there. The things that we have right now, the UPI, the CoWIN platform, the digital public health goods, they are still a vision, they are still a dream in many other developed economies right now. So I want you to appreciate that and want you to see how overall India is evolving and what it means for the healthcare sector. Better reason to say that because there is no better reason for that because we are getting rich actually. It's a matter of fact that we as a society, we as a We have been talking about the rising middle class for years now. That is something which is happening right now. We have been talking about things like, for example, the luxury cars, most of the cosmetic brands, they do find a presence in the country right now. This is a reality right now. And this is something we should be proud of, and this is something that is also driving many changes in the healthcare sector. We have become a lot more aspirational right now. That difference between what is a need, what is a want, what is a desire is getting abolished in the healthcare. No more is a time when a patient will have to go to a hospital to seek a care. It's like, for example, in the 1970s, when I'll go to a bank to withdraw the money and the cashier will say, it's my money actually that I'm lending to you. No, it's not the case right now. Today, the patients or the customers or the consumers, they are a lot more demanding. They want the healthcare to be delivered at their home set. They want the healthcare to be delivered in a manner which they want actually. We have been talking about healthcare which is accessible and affordable. It's gone now. Today, the care should be more accountable. The care should be more acceptable, and the care should be more available actually. We are not talking about accessibility, affordability. We are talking about accountability, availability, and acceptability. A new paradigm shifts of the way we are looking at the healthcare. I'll give you a simple example how this ecosystem is evolving. This is a pretty simple flow chart on how the ecosystem might have looked like a couple of years back. You will have the manufacturers of the pharma company. You will have manufacturers of the medtech company. They will have an elaborate supply chain. The supply chain will deliver it to the public hospitals, the pharmacies, the diagnostic company. It will go to the patients. And in some cases, you will have the insurance, the TPA. Pretty simple, pretty linear, elaborate, simple chain that was existing till a couple of years back. If someone were to ask, like, for example, what is happening right now, this is what is happening right now. You have multiple stakeholders which are breaking the entire value chain. These are the players who are delivering specialized services. These are the players who are driving the shots right now. Can you go to a hospital without having a quality expert? Not possible. Can you go to an insurance company without having someone who can expedite the claim? Not possible. Can you go to a logistic company without having a GPA? Not possible. Can you go to a diagnostic company who is not using AI/ML? Not possible at all. So unless you are aware of how the ecosystem is getting disrupted, who are the new players, you will not be able to appreciate the gravitas that we're seeing in the ecosystem right now. Things that are happening or that we are studying right now, they might become obsolete in the next 5 to 10 years. It's pretty important that we stay on path as to what is happening in the ecosystem, and we get familiar, we get aligned how this thing is shaping the healthcare that we seek today. I'll give you one more example. The diagnostic ecosystem. Diagnostic ecosystem I have taken because this is actually the fulcrum around which everything else revolves. If you break it down, the diagnostic ecosystem, it is actually a series of small value chain steps. An order is generated, you collect the sample, you transport the sample, you prepare the sample, you analyze the sample, and then you generate a report. It's a series of steps that is happening in a diagnostic ecosystem. A true management consultant breaking down a problem into subcomponents, this is what we have done over here. Now the beauty is that try and appreciate how this has been broken down in the last couple of years. Before 90s, all these steps will happen in one center. The patient will come over there, he will ask for the test over there, the sample will be taken, the sample will be prepared, the report will be delivered, everything at one center. In 1990s, I think Dr. Lal Pathlab was the first breaker. He set up the phlebotomist centers, the collection centers part gets separated out. The phlebotomist was there, his only job was to collect the sample, and the rest everything was taken care of at some other place. The value chain started getting unbundled. In early 2000, 2010, we had this online aggregators who took away the path of the order generation also. We had the Practos and we had the 1MGs who started collecting the orders. We come to the late 2010 and we saw the logistic partners actually. These are the players who will collect the sample and transfer from a sample collection unit to a lab, breaking the or unbundling the value chain once again. And today what we are seeing, there are players actually, for example, AirMed and all that, who are using AI/ML to break it even further. What is happening is that there is a camera that is going to be mounted on a microscope which is preparing the slide. That camera or the AI is going to relay the images. The pathologist or the microbiologist is going to sitting in some other quarter of the country. He'll analyze the sample and he'll deliver the report. You see how technology or how the demands of the patient, they are breaking the value chain. This is only one example. I'm sure if you were to think it through the hospitals or the pharmaceuticals or any other part of the value chain in the healthcare, you will find similar examples. The idea is to appreciate how the new ecosystem is evolving, how the traditional models have been getting broken, and how the new ecosystem that we're looking at, health system, that is getting shaped up right now. We had a classical thing that doctor is probably sitting at the center of the ecosystem. doctor drives the entire healthcare. It was a provider-led model. What doctor says, the patient will follow. What doctor says, the insurance company is going to reimburse. And what doctor says is probably going to be followed by the healthcare consultants and the management and the regulators also. That pendulum is getting shifting right now, and probably the payers are the new stakeholders in the ecosystem. If an insurance company says that I will not be able to reimburse that, doctor would have a minimal motivation to prescribe that drug. If an insurance company is going to say that, okay, you should be writing a drug which is like, for example, having a better HTA, a better HER score, a doctor or a hospital might be willing to do that. We are working with some of the industry associations, we are working with some of the payer associations also. And I think this is a burning topic right now. How do you bridge that payer-provider trust deficit, and how do you make it happen on one single platform? The government has become a lot more proactive than probably what it used to be. It has taken on a new shape and new mechanism altogether. When I did my MBBS, the number of seats were very different from than what we had right now. There was simply not that opportunities of the post-graduation that we see right now. Number of seats has expanded. I think we have taken on a new mandate, a new driven purpose that the healthcare indicators, number of doctors, number of hospitals, they should meet the WHO norm much before that. SDG goals. We were hoping that we will reach by 2030, but the newest indicators show that we might be able to achieve some of them pretty early also. Other initiatives. The government of India has launched the Prime Minister Jan Arogya Yojana program, the ABDM. ABDM is actually the world's largest single healthcare digitalization program. Nowhere in the world has this particular kind of a mandate been taken at this larger scale, which is happening in the country right now. So this, what we are seeing, is a new paradigm shift happening. The role of the government is getting changed. It was actually a provider, now it's becoming a payer. And last but not the least is the role of the healthcare automation or the healthcare AI. Now, see, AI, I mean, I won't go into the Gyan part of it. Gyan, we all know, understand. AI can have multiple use cases. But I want you to appreciate that when you enter this particular space, when you're designing the use cases, you may start to think from a business perspective how the AI is going to be embedded in the business cycle and how the business will actually drive the maximum value out of it. We will have multiple classifications of AI, what it means for the healthcare ecosystem. But essentially, if you break it all down, you will find 4 broad uses. The first one is you can use AI as a clinical decision support adjunct. You can have a patient app, you can upload the system over there, data over there. You can have a physician who can read the lab reports, who can read the medical reports, who can make a decision. You will have monitors who can tell how the patient is going to progress in an ICU, what is going to be the fall rate, things like that. So that is the first use case, which is as a clinical decision support adjunct. The second use case that we are seeing is as an operation improvement tool. AI is going to be leveraged heavily in a hospital for an operations part. I'll give a simple example. Discharge summary. Discharge summary is a document given to the patient at the time of discharge. But if you look at the discharge summary, what is it actually? It is nothing more than a summarization of the patient records during his entire stay in the hospital. It's an organic document that starts getting prepared the moment the patient is admitted in the hospital. So day 1, this is the clinical flow, this is a part of the summary. Day 2, this is the clinical workflow, this is a part of the summary. AI, Gen AI, OCR can do it wonderfully. It's like, for example, uploading 7 documents in the system and asking the system, can you give me a clean, crisp, standardized discharge summary? The Gen AI can do it in a matter of a click of a button, and it is much more standardized, much more clean than what we have right now. It saves you the FT cost, it saves you the clinical inaccuracy part, it saves in the FT cost, and it also helps in drive a lot of standardization. Third thing that we are seeing AI is as a patient assistant. As a patient assistant, the patients are carrying this in a mobile app, in a wallet, things like that. In fact, you know what is the latest trend right now? All the hospitals, all the labs which used to have their standalone health app, they're trying to convert that into a patient assistant or a super app kind of a thing. So instead of being able to see only lab diagnostic report on the lab diagnostic app, you can see all your health records over there. You can book an appointment, you can order a medicine, you can seek a consultation, you can do a test also. Everything is going to happen on that one simple patient health assistant app, which is going to be driven by AI. A classical shift, we are taking the AI from B2B to B2C actually, and this is in a way trying to democratize the power of AI, which is actually going to reach the new million over there. And the last but not least is the regulatory tool. I'm being told that we are getting some increasing queries of lawyers as to how AI is going to be used in the legal space, and the medical legal is becoming all the more important. Medical laws, pretty convoluted. difficult to decipher what is written over there. You have the acts, you have the laws, you have the forms, you have the rules, and then you have the digital pronouncements also. Doctors, they are not taught law in the school. They don't have any idea of that, not even an iota of it. This Gen AI is being used as an assistant over there. It's like a simple chatbot. You ask your query, you ask the system what they can do, what they cannot do, and the tool can help you prevent those years behind the bar. So this is how we are seeing Gen AI evolving in the industry across these 4 buckets. I hope I was able to complete my presentation in 15 minutes actually. I just want to...
Yes.
Okay, thank you. Thank you. I just want to leave with a thought actually. If I were to ask you, like for example, in which year did the man land on the moon for the first time? Many of us might know that actually the answer is 1969. But if I were to ask you, like for example, when was the last year the man landed on moon? Many of you may find it surprising, actually it was 1972. So 1972 and 2026, almost 50 years have lapsed, more than 50 years, but a man has not landed on the moon. The reason, because there was no business imperative. We could not find any resources on the moon. We did not have any usage on that particular part of landing a man on the moon. And the technology that we had in 1970s simply deciphered away. We strongly recommend that we are using AI. We should find a clinical application, a business application, so that the technology is not lost and it's going to get used all the more often. So I just want to leave you with that particular thought, and all the best for the conference. Thank you.
Thank you. Thank you, Dr. Ashwani. So wonderful. And let us know the paradigm shift with the use of AI in healthcare industry, which making more accessible and affordable to the users. So now we move to the next speaker. Over to you.
Thank you, sir. We deeply appreciate your time and contribution to this conference.
Our next speaker is distinguished leader whose work bridges the public health, environmental sustainability and development communication. Dr. Vivek S. Agarwal, sir, founder of the Center for Development Communication.
Dr. Agarwal is a medical...
Sure, sir.
थैंक यू सो मच। और जब मैं IIHMR में आता हूँ तो मेरे को लगता है कि मैं मेरे घर में आ गया हूँ, क्योंकि मैंने कैरियर की शुरुआत यहीं से की थी। और बड़ा डिफ़िकल्ट है, लेकिन जब हमारे सीनियर यहाँ पे बैठे हों, मेरे मेडिकल कॉलेज के, विद्यालय के, स्कूल के सीनियर डॉक्टर महेंद्र कुमार जब यहाँ पे बैठे हों, तो एक मन में भय रहता है ना कि इनके सामने कैसे बोल सकते हैं, लेकिन कुछ प्रयास करेंगे। अभी अगर आप इजाज़त दें तो आजकल सबसे बड़ी चर्चा जहाँ AI की चल रही है, एक दूसरी चर्चा और चल रही है। अभी अश्विनी जी ने बोला कि 2030 तक कुछ लक्ष्य प्राप्त करने हैं। कौन से लक्ष्य हैं? SDGs क्या है वो? नाम तो सब बता देंगे, सस्टेनेबल डेवलपमेंट गोल्स, लेकिन आखिर है क्या? सस्टेनेबिलिटी वास्तविक रूप में है क्या? आज सवेरे जब कुंबर साहब बोल रहे थे तो मैं उनकी बात को सुन रहा था। उन्होंने बड़े अच्छे से कहा कि आम तौर पे सोच होता है कि ये या तो पर्यावरण की बात कर लो या कोई आर्थिक रूप की बात कर लो, लेकिन एक और पक्ष है। कौन सा पक्ष रह गया? सस्टेनेबिलिटी में 3 मूलभूत बातें हैं। कौन सा तीसरा पक्ष है जो कि सबसे मजबूत है लेकिन सबसे ज्यादा उपेक्षित भी है, इग्नोर्ड? कौन सा पक्ष है? गौतम जी तो बता ही देंगे, लेकिन बच्चों में, कोई स्टूडेंट्स में, कौन सा तीसरा पक्ष है जो कि सबसे ज्यादा आवश्यक है लेकिन सबसे ज्यादा उपेक्षित है? एनीबॉडी?
It is the social aspect of it. Unless we deal with all 3 pillars of the sustainability, that is environment, economics and the society together, we cannot achieve sustainability. इसको बड़े अच्छे से याद रखना। और
जब सोसाइटी की बात करते हैं तो उसमें स्वास्थ्य से बड़ा कोई चीज नहीं। एसडीजीज में भी है ना एक स्वास्थ्य को कैसे प्राप्त करना, लेकिन एक और एसडीजी की बात करना चाहूंगा उससे पहले कि अपनी बात को, क्योंकि ये सब कुछ उसी से जुड़ा हुआ है। कितने एसडीजी गोल्स हैं? 17। 12वां गोल कौन सा है? लक्ष्य 12वां कौन सा है? एनीबॉडी? गोल 12। नो, दे हैव द विजडम। मेरे जैसे लोग जो विजडम में नहीं है, लेकिन मैं तो देखो, मैं आप वो परिचय से इसलिए भी रोक दिया कि कोई बड़ी बड़ी बातें करेंगे। मैं मूलतः कचरा उठाने वाला एक कचरा श्रमिक हूं, ये मेरा परिचय है। तो कौन सा है लक्ष्य 12वां? रेस्पॉन्सिबल कंजम्पशन। सबने देख ही लिया होगा ना अभी तो गूगल पे। यही तो एआई की बड़ी महत्ता है और गूगल की महत्ता है कि रेस्पॉन्सिबल कंजम्पशन। आर वी रेस्पॉन्सिबल? व्हेन वी टॉक अबाउट द हेल्थ अगेन, आर वी बिहेविंग रेस्पॉन्सिबली? आई एम नॉट टॉकिंग अबाउट द कंज्यूमर अलोन, आई एम ऑल्सो टॉकिंग विद द पर्सपेक्टिव ऑफ द प्रोवाइडर। And honestly saying, we are not responsible. बजट कितने लोगों ने देखा अभी हेल्थ वाला? जो केंद्रीय बजट आया उसमें हेल्थ को एलोकेशन बढ़ गया, लेकिन बढ़ा किधर पे है? गत वर्ष का भी बजट देखें, इस वर्ष का भी बजट देखें, बजट बढ़ा किधर है? जब हम प्राइमरी हेल्थ केयर में, उसमें आया है कि प्राइमरी हेल्थ केयर का बजट बढ़ गया। पिछले बार भी ऐसा हुआ, इस बार भी ऐसा हुआ। गत वर्ष भी बढ़ा, इस बार भी बढ़ा। लेकिन बढ़ा किधर है वो प्राइमरी हेल्थ केयर का बजट? प्राइमरी हेल्थ केयर है क्या? प्राइमरी हेल्थ केयर है क्या आखिर? सिर्फ आयुष्मान मंदिर बना देना, एक भवन का निर्माण कर देना, क्या प्राइमरी हेल्थ केयर का इतिश्री हो जाएगा उसमें? क्या उससे मिल जाएगी प्राइमरी हेल्थ केयर? अगर हम देखते हैं कि जितनी इंटेलिजेंस हुई है, चाहे वो आईटी का रिवॉल्यूशन हुआ हो या अभी एआई का रिवॉल्यूशन हो रहा है, इसमें सबसे ज्यादा आहत कौन हुआ है? इसमें सबसे ज्यादा आहत हुआ है समाज, सोसाइटी, क्योंकि एक गैप जो है वाइडन होता जा रहा है। हैव्स और हैव नॉट्स के बीच में एक जो खाई है वो बनती जा रही है और कहीं पे कुछ चीजें केंद्रित होती जा रही हैं और अगर हम पेरिफेरी की बात करें तो वो वंचित होते जा रहे हैं। क्या ये सही सामाजिक व्यवस्था है या सामाजिक विकास है? क्या ये सस्टेनेबल डेवलपमेंट है? तो मित्रों, वहीं से अपनी बात को प्रारंभ करता हूं कि अभी अंतरा फाउंडेशन की जब बात कर रहे थे तो कैपेसिटी बिल्डिंग की बात कर रहे थे, आपने अश्वनी जी ने बात की, बहुत अच्छी, वो तो आवश्यक है ही, लेकिन इस गैप को कैसे दूर किया जाए? आज जो सारा हो रहा है, स्वास्थ्य की जब बात करते हैं हम, तो स्वास्थ्य के केंद्र बन गए हैं शहर। स्वास्थ्य के केंद्र बन गए हैं शहर, और जो हमारी पेरिफेरी होती थी ना, पहले सब सेंटर होता था, कम्युनिटी हेल्थ सेंटर होता था, प्राइमरी हेल्थ सेंटर होते थे, इवन फॉर दैट मैटर हमारे डिस्ट्रिक्ट हॉस्पिटल्स भी अभी अपनी जो महत्ता है उसको खोते जा रहे हैं। क्यों खोते जा रहे हैं? कभी सोचा इस बारे में? कंज्यूमरिस्ट सोसाइटी तो है ही, लेकिन जो जितना प्रचार प्रसार ये सारे मेडिकल इक्विपमेंट्स के बारे में होता है, तो इंसान को ये लगता है कि शहर में वो उपलब्ध है जो मेरे गांव में उपलब्ध नहीं है। एक थोड़ा सा बैकग्राउंड देना चाहूंगा इससे पहले कि मैं अपनी बात को विराम दूं। क्योंकि डॉक्टर महेंद्र कुमार के आदेश है कि विराम देना है। हाँ, 7,000 तरीके के मेडिकल इक्विपमेंट्स विद्यमान है। कितने? 7,000। और भारतवर्ष में, भारतवर्ष की बात कर रहा हूं मैं वैश्विक बात नहीं कर रहा हूं, भारतवर्ष में कितने ऐसे इक्विपमेंट्स कबाड़ में पड़े होंगे? कबाड़ जानते हैं? कितने लोग जानते हैं कबाड़? रेज योर हैंड्स। देखिए, कबाड़ को जब तक नहीं जानेंगे तब तक अपन सस्टेनेबिलिटी की या अपने स्वास्थ्य की या अपने स्वयं की भी बात नहीं कर सकते, क्योंकि कबाड़ वो जगह है जहां से कि निर्माण होता है। कितने इक्विपमेंट्स कबाड़ में पड़े होंगे आज भारतवर्ष में? एक मोटा मोटा आइडिया, गूगल पे नहीं मिलेगा। 20 लाख से ज्यादा इक्विपमेंट्स कबाड़ में पड़े हुए। और अगर पेरिफेरी को सैचुरेट करना है, वहां तक इन इक्विपमेंट्स को पहुंचाना है, तो हमारी रिक्वायरमेंट कितनी है? 10 से 15 लाख कबाड़ में पड़े, 20 लाख और अधिक। ये तो 20 लाख तो रिकॉर्डेड है, लेकिन आवश्यकता है 10 से 15 लाख की, जिससे हमारे जो अंतिम छोर पे व्यक्ति है उस तक ये इक्विपमेंट पहुंच जाए, लेकिन नहीं पहुंच रहे हैं। दूसरा एक पक्ष और देता हूं आपके लिए, इट्स जस्ट फूड फॉर थॉट। देयर नीड टू हैव अ पॉलिसी ऑन ऑल दीज थिंग्स। हम आकर्षित कैसे होते हैं किसी भी इक्विपमेंट के लिए, किसी भी डायग्नोस्टिक के लिए आकर्षित कैसे होते हैं? यदि मेरे को एमआरआई करानी है तो मैं क्या देखता हूं? मेरे को, मेरे परिवारजन को, मेरे किसी जानकार को वो देखता हूं कि उस पर 1.5 टेस्ला लिखा है, 3 टेस्ला लिखा है। देखते हैं ना? देखते हैं या नहीं देखते हैं? ये एक आम जन का सोच है। 1.5 टेस्ला, 3 टेस्ला, कोई आम जन समझता नहीं है कि ये टेस्ला होता क्या है, लेकिन नंबर क्योंकि ग्रेटर है 3, तो वो कहेगा कि मेरे को तो 3 टेस्ला पे बेहतर एमआरआई होगी। सीटी स्कैन कितने स्लाइस वाला होना चाहिए? अब तो 640 स्लाइस का भी आने लग गया। जाता कहां है? जो ज्यादा से ज्यादा ग्रेटर नंबर दिखे, मैं उसकी ओर आकर्षित हूं। उसकी आवश्यकता कितनी है? क्या हर बीमारी के डायग्नोसिस के लिए उसी प्रकार से अल्ट्रासाउंड की बात करें, किसी की भी बात करें, उसकी आवश्यकता किस बीमारी के लिए, किस ऑर्गन के लिए कितनी होती है, ये हमें भान ही नहीं है। लेकिन मार्केट चला रहा है और हम मार्केट के साथ साथ बह रहे हैं, और इनका घनत्व शहरों में बढ़ता जा रहा है, डेंसिटी बढ़ती जा रही है। और डेंसिटी बढ़ने के साथ क्या हुआ? आप लोग तो मैनेजमेंट के विद्यार्थी भी है ना? डेंसिटी बढ़ेगी तो मार्केट में कंपटीशन होगा, उनके पास एडिक्वेट नंबर में पेशेंट्स नहीं होंगे एक मशीन के ऊपर, तो उससे कॉस्ट का बढ़ावा। और सबके पास जो भी उस मार्केट में बैठे हैं, एक प्रतिस्पर्धा होती है कि उसको किसी न किसी तरीके से अपग्रेड करें। उस अपग्रेड की कॉस्ट भी आपको ही वहन करनी है। सो coming back and to conclude, can we have a system, can we have a policy using the AI which can diagnose on the concurrent basis the health of these equipments and machineries? यदि इनकी हेल्थ का कंकरेंट तरीके से डायग्नोसिस हो जाए कि ये कहाँ पे और कैसे उपयोगी है, और जब ये इनको आगे बढ़ाते जा रहे हैं तो उनको पेरिफेरी के साथ क्यों नहीं जोड़ दिया जाए? यदि पेरिफेरी में इनको जोड़ दिया जाए तो ये कबाड़ की शोभा नहीं बढ़ा के वो अंतिम छोर पे जो व्यक्ति है उसको वो सुविधाएं नहीं। जब हम सस्टेनेबिलिटी की बात करते हैं ना, तो सस्टेनेबिलिटी की बात में पर्यावरण को बहुत ज़्यादा महत्व देते हैं। आज पेशेंट क्या हो रहा है? सीधा सीधा शहरों की ओर आ रहा है। कितना कार्बन फुटप्रिंट उसका उसके साथ जुड़ा हुआ है। कितना उसके साथ उसका अर्थ जुड़ा हुआ है। कार्बन फुटप्रिंट और अर्थ को जब तक हमने, और उसका समय, उसका परिवार किस तरीके से उससे आहत होता है, उससे किस तरीके से प्रभावित होता है, यदि ये मशीनें हम किसी तरीके से भी उस और आमुख कर सके, इनको ओरिएंट कर सके, तो आई गेस कि हम लोग प्रेजेंटेशन आप लोग बाद में देख लीजिएगा, कुछ एक स्लाइड्स हैं कि कितने आज हमारे पास मशीनें हैं, लेकिन इनका फोकस कहाँ पे है, कहाँ पे इनकी आवश्यकता है, कैसे हम इनको एक सिस्टम जो आर्टिफिशियल इंटेलिजेंस को, इससे रोजगार भी सृजित हो, लोग वहाँ पे रहेंगे। जो अब्दुल कलाम साहब का एक सपना था ना, गांव के शहर जैसे, बिल्डिंग बनाने से शहर नहीं बनते हैं, वहाँ पे सुविधाओं से शहर बनते हैं। स्वास्थ्य उसमें प्रमुख ऐसी सुविधा है जिसको कि उन्नत करना पड़ेगा। सिर्फ आयुष्मान मंदिर बनने से हमारा ये स्वप्न साकार नहीं होगा। धन्यवाद।
Thank you, Dr. Ji, for making us aware of reality.
Realities of gaps in healthcare delivery system, and we are thankful to you. This is a man who speaks from the periphery or ground, from the ground, because he has been connected with, yeah, and definitely it gives me pride and to be connected with you. Thank you. So we can move to the next speaker.
Thank you, sir.
We are honored to welcome our next speaker, Mr. Hemant Bhatnagar, sir, Facility Director at Narayana Health.
He is a senior healthcare administrator with vast experience in hospital operations, quality accreditation, and healthcare standards.
Please join us in welcoming Mr. Bhatnagar.
Thank you very much. It's an honor and privilege to be here today. Definitely. And more, it is nostalgic moment. And I was connecting from Agarwal Sahab. सर ने अपने करियर की शुरुआत यहाँ से की है और मैंने अपने प्रोफेशनल जर्नी की शुरुआत यहाँ से की है. I'm in the same auditorium where today where you are sitting, I used to sit 25 years back and listen to our eminent professor. थोड़ा सा मोनोटोनी को ब्रेक करना चाहूँगा सेशन की, not exceeding the time. और जब मैं वहाँ बैठा हुआ था तो मैं रिलेट कर रहा था कि कबीर दास जी की जैसी स्थिति हुई थी एक ज़माने में कि उनके सामने गोविंद यानी कि कृष्ण भगवान और गुरु दोनों सामने खड़े हो गए. तो कबीर दास जी कंफ्यूज हो गए कि मैं किसके चरण पहले छूं, ईश्वर के या गुरु के. आज मैं इस बात को अच्छी तरह रिलेट कर सकता हूं और पूरे सम्मान के साथ कह सकता हूं कि वी मस्ट टच द फीट ऑफ आवर गुरु फर्स्ट, बिकॉज गुरु गोविंद दोनों खड़े काके लागू पाए, बलिहारी गुरु आपकी गोविंद दियो बताए. I cannot complete this statement without mentioning respected S.D. Gupta sir, Sodani sir, Nutan madam, Hem Bhargav sir. Sir बैठे हुए सामने, you can't relate, I am having goosebumps. Anyway, thank you very much the organizing team for inviting me for this session. I will not take much of the time. All the tone setting or the context setting has been done by eminent speakers in the previous session. They have shared their experiences with the government setup, the initiatives, and with the consulting from PwC by Dr. Agarwal. What I'll try to do, I'll try to stick to the topic which has been assigned to me, that how we can transform community health by using AI. But the most important aspect is the man behind the machine, the behavioral change. And how practically in community health this is actually happening. As well as I'll also try to share a couple of my examples which we are using at Narayana Health practically and try to justify whatever topic has been assigned to me. So current healthcare scenario, I need not to reiterate the same challenges, just focus on the bottom line. Urban-rural divide, 70% of the rural population, 80% doctors are based out at urban areas. There is a shortage of doctors to patient, there is a shortage of doctors to nurses, and patient is to nurses as well. Disease burden, Non-communicable diseases are tremendous. Infectious diseases are spreading. Data, we have tremendous data, lot of data available, plenty, but it is fragmented. It is not structured. And if we see all these years, the Mudaliar Commission, which started it functioning after independence, we have been doing lot of models. We have been trying, Planning Commission has been trying to implement lot of things, but why these models are not sustainable? Why this model got failed? Three core reasons. The first is we had data, but without implementation or use of intelligence. We intervened as per the requirement. हर बार नए परिवार नियोजन के, कभी family planning के, कभी based on the programs keeps on coming, but it was not as per the ground reality. And third, we try to use the technology, but without trust. In the morning session, the Vice Chancellor spoke about it, that trust is the only factor which makes the entire difference. So these three are the core reason, or agar hum तीनों को जोड़ें, what one word which misses in all this scenario is synergy. We are not able to synergize our efforts, and that's how now we are switching to AI, which is opening us the plenty or plethora of opportunities. How, with the use of AI and with the implementation or transformation of behavioral sciences, what miracles we can do on ground. First, AI capabilities, I need not to explain. It definitely provides the structuring of data, risk prediction with proper precisions, surveillance programs, clinical decision support systems, CDSS. Sir has also shared about his rural examples, that how government is reaching to the rural population by use of CDSS, clinical decision support system. But ultimately that will be successful if we have the frontline worker involved in it. The workforce, the ASHA worker, Anganwadi, or the PHC, CHC nurse, then it is actually implementable. So the behavioral sciences require nudges or constant reminders. It needs to have a local connect, linguistic connect, usable workforce, and habit formation. If we use these 3-4 core techniques with intelligence plus influence, we can definitely create miraculous impact, and we cannot, it is actually happening. Few examples where AI meeting the behavior, how it has transformed the current healthcare delivery system at community health system. I'm not talking about the corporate, I'm talking about the rural scenario. E-Sanjeevani plus AI CDSS software. I am also a National Quality Assurance assessor, and I visit a lot of government hospitals in the capacity as a principal assessor. And every time I get astonished to see that actually at ground these things are getting implemented. So this is one software which has already reached these numbers you can read on the slide. Care Neonatal, sir has already referred initially that they have developed this app which is monitoring the, which is providing the maternal and child health solution in rural areas. NemoCare Raksha software which monitors the neonatal vitals, which will provide the clinical support system to the neonates to reduce the infant mortality rate. Predictive prioritization, based on the data, we can definitely augment and prioritize our program that where the intervention is required. Finally, this screenshot, I could not resist myself to keep it and include it in my slide. All these 4-5 points which I've shared just now, this is the realistic implementation on ground at rural areas and to reach out the community, where the ASHA worker can easily communicate in the local language and get the results. 869 ASHA workers, 24,000 queries are answered by use of AI with 100% government compliant and no deviation. I mean, without the use of AI and machine, humanly, that would not have been possible. The love area, corporate hospitals, coming to Narayana, another perspective. What we are doing at Narayana Health. We have 52 hospitals across the country, 10 hospitals in United Kingdom, 2 hospitals at Cayman Island, 55,000 total workforce, pan-India presence. Led by Dr. Devi Prasad Shetty, who is the father of Digital India, who is the father of Yashaswini Yojana in the country. आज की जो आयुष्मान भारत योजना है, इसका आज से 20 साल पहले, he started the concept by offering 1 rupee insurance to farmers in Karnataka. So that's how they started, and he has one very commonly used dialect. he wants to disassociate healthcare quality from affluence. You will see his multiple interviews on the YouTube, and he time and again insists that how with the use of technology we can disassociate that wealth of an individual or a nation will allow him or her to reach or to get the quality health care. How we are actually using the technology in our hospitals to provide that digital and AI assisted services to our patients. Our entire ecosystem works under the umbrella of the software called Atma. You can see that there are different verticals which are linked to the one central Atma source which can be monitored at the central level and which provide real-time decision-making system. I mean, it is good for the patient but very risky for people like us, those who are accountable for profit and loss of the unit. Because our leaders, by sitting there in Bangalore, can see what is my occupancy at the Ahmedabad unit and what is my business prediction. But the point I'm trying to make here is that with the use of AI and technology, rather than moving to predictive or reactive situation, we are more pragmatic and realistic in terms of our approach. This is just a snapshot of our data tools and digital tools. As I said, that how we are getting the real-time insight. The first green and red talks about the products, the business value, the volumes. Similarly, the patient satisfaction this thing, what is the score? These are the geographical distribution of my patient. I mean, this is a damn useful tool that as a head of hospital, I can make out from where I am getting the patient and what is the density and what is my catchment area. We read from Gupta sir about the catchment area and demographics, but actual implementation today we are able to do that by use of this AI. Last, this snapshot, this screenshot is definitely a sum up of the overall functioning of the unit from all angles, from patient perspective, from service excellence, from business, from consumption, so on, right, which are highly important for the P&L account of any entity, be it a government or be it a private. These are again few snapshots by use of AI we are doing. We are also providing solution by use of AI for X-ray reading and CT scan. I want to share one funny incident when I got the AI assisted MRI installed in my hospital, and the promoter, the person who has installed that machine, started boasting a lot about the machine capability to the extent that it can also read the patient images and can provide the diagnosis. The radiologist came and asked, sir, hame rakhoge ki nahi rakhoge? No, that's not the scenario. Actually, the machine will assist with the use of AI more precision, that where need to be focused, how the angle, how the slice need to be taken. With that, ultimately, the misses which usually happen at the human level would be a remotest possible, because now machine is using the technology as well as we are coupling up with the capabilities of the doctor. So these are the few tools which we are using. We are also using wearable gadgets which can monitor patient cardiac rhythms back home. Patient need not to come to the hospital. Sitting at home also, a doctor can monitor the cardiac status of the patient. This is again an initiative by Dr. Shetty to reach out the patients and they need not to come to the hospital. Quick learnings and summarize the session, that I started saying that whatever intervention, whatever use of data, whatever technology, it has to be synergized. If it is synergized, success definitely is bound to happen. Start with operation. No point talking from air. Please try to relate it with the ground reality. Agarwal sir, just now I talked about a lot of kabad and equipments. Basically, sir was trying to relate that with the ground situation. What is happening on ground? By talking in conferences, things won't change at the ground. We need to be more realistic and practical. We need to be transparent and trust. Ultimately, without exceeding the time, I'll take another minute to give you the ground situation. Because all the eminent speakers are sitting here, one consultant, one ground expert, one teacher, and one from ex-army person, and come teacher also. Today, if you see as a patient, and if you see the healthcare insurance scenario, there are three. If you imagine a triangle, on one side we have the insurance provider, the health insurance companies, right? On one side there is a service provider, the hospital. Practical situation is, hospital don't trust insurance company because they say that they are trying to bargain, they are trying to take the lowest possible tariff from me. They will try to give the best, lowest possible tariff to the insurance company. Insurance company will always try to cut their claims because they have to maintain their claim ratios. So they don't trust the hospital. Mr. Agarwal, Dr. Agarwal talked about the discharge summary, right? Discharge summary, while you are preparing the discharge summary, insurance company have started reading those discharge company by use of AI. Because the trust is missing between the hospital and insurance company. And finally, at the bottom, you and me, as patients, we don't trust both. Yes or no? Neither we trust hospital nor we trust the insurance provider. So that is the fallacy. The point here I'm trying to make, ultimately it is the trust. While you use the technology or while you introduce any new system, if you are able to gain the trust and confidence of the workforce or the user end, then everything can be implemented nicely. Finally, we need to sustain consistently, scale it up to reach to the best possible level. Ultimately, if I have to say, and if I have to sum up with a lot of dignity and respect, we need to follow our leadership. As he rightly says that he has a dream of reaching on providing quality health care which reaches to the bottom or the deepest possible, garib vyakti tak, rural vyakti tak pahunche. If I have to say in management jargon, and if I have to sum up my presentation, all I can say that AI must not replace compassion. It must amplify it. The data must drive decision, but our behavior, our means the workforce behavior must drive adoption, because without the combination of synergy of these two, it's not going to implement it. And from a smart hospital, we should move to smart communities. Rather than treatment, we should move to more prevention, more awareness, because we wanted to provide access to equally to all the people of the country. Ultimately, digital health is not about machine. It is about people. Thank you.
Thank you. Thank you, Hemant ji, for making us aware about the ecosystem with the AI-enabled health delivery. So Narayana is definitely, Narayana Health is one of the leading, which is using AI-enabled, eco-friendly and, patient-friendly system. So by the time we prepare for the felicitation, I think we are already running behind time due to the late start also. And so we can allow only 1 or 2 questions. If you have any questions, so we can take those.
Maybe please have
anyone? Yeah, we'll take 1 or 2 questions.
Yes.
So yeah, Dr. Vinod. Someone is looking like Dr. Vinod. He's not Dr. Vinod. Okay. Sorry. Flashlight. Okay.
Good afternoon, sir. Myself, Dr. Niranjan. So, India healthcare is steering towards high quality, sir. So, will this make us move forward towards preventive care, or will we stay focused towards the treatment aspects?
Your question is to whom?
Sir, to all, sir, because...
To all, you have to have choice. That is the problem with young generation. You must have focused approach.
For Ashwani Agarwal, sir.
You are ready? Okay.
Yes.
The change which has happened during last one or 2 decades. Earlier we had the definition of health, a different one. And we used to classify health and medical differently. But what has happened over the period of time, we have clubbed these two. We even consider the medical facilities as the healthcare facilities, which is not true. Health was basically the preventive aspect. So when I was talking about the primary healthcare budget, you will find that primary healthcare budget is not for the prevention or promotion. Because currently, you may not agree from the corporates or the consulting or all this, that the medical care, I do not use the word healthcare, but the medical care which is being implemented is largely governed by 2. And they are insurance companies, and the pharmaceuticals. No one else. So we do not have a movement. Earlier we used to have a movement where we were talking about health, and as per the national health policy, 1% of the budget should come to the health sector. And when we talk about the health sector, it is mostly the preventive and promotive health, which we have ignored largely now.
I hope you have understood. If not understood, you can continue during the lunch. Last question. Yeah, is there? Yeah, only one. Because I don't want be the reason to be between you and the lunch. We have to finish fast.
Hello, sir. My question is for Dr. Ashwini, sir. So, because of we are seeing that there is increased fragmentation in global health funding and delivery models. So, in this current scenario, how can huge advisory firms like PwC help governments build a more resilient and, most importantly, a shock-proof health system?
I mean, that's a very difficult question. So still, let me try. So, see, नहीं आंसर क्लियर होना चाहिए सर. So see, we always say that never let a crisis go waste. Probably crisis is the best time to introduce new reforms. अभी ट्रम्प ने टैरिफ लगाए थे, we saw multiple reforms getting introduced. हमारा लेबर कोड हो गया, उससे पहले हमारा GST implement हो गया, and the things which were stalled for so long, they started getting in motion. We had those telemedicine guidelines which were stalled till 2000, since 2000. COVID आया, and within I think couple of weeks those guidelines got passed. So I think crisis is a perfect opportunity to let the reforms roll and make the best use out of it. Stock market में when your share price go down, probably that's a good opportunity to buy and make the best use of it. Something similar we believe is going to happen on the healthcare side also. What's going to happen is that we used to have a fragmentation of multiple funds. We used to have funds being given for different purposes which are operating in silos. What we are seeing now is an attempt to consolidate those funds, make meaningful interpretation out of it, and start focusing on outcomes instead of input processes or outputs actually. That's the first thing which is happening. Second, I think because there is a realization that the financial elbow room that you have, the kitty that you have, is going to be limited. And you may not have those flexibility to do those overheads kind of a thing. We are finding that the budget is getting rationed from perspective like, for example, 85% has to go on the development part and only 10-15% has to go on the monitoring part of it. And last but not the least, I think it's the technology which is getting answer to many of the problems that we used to have. How you can use technology to deliver healthcare in a much more better manner. India, classical example, we used to have an out-of-pocket expenditure which was like 71% as a percentage of the current health expenditure. This was like 2019. Recently, we are broaching the barrier of around 39%, 39.5% actually. It's a significant drop, not happened anywhere in the world. One reason is technology, the way we have been able to leverage that. PMJY, classical example, everything is made on technology only. It's a paperless scheme. We have those fraud analytics and AI/ML solutions also over there. So I think this is how the attempt is to make use of whatever money we have. Money is never going to be sufficient actually. It's never going to be sufficient. We have 1.1% of the healthcare, public health spend going on the healthcare. Even if we achieve 2.5%, it's still going to be less actually. So I think while we should always aspire to have higher sources of revenue, increase the money, the idea is to make best use of what we have using technology and other measures. I hope I was able to answer a part of the question, not completely for sure.
Thank you, sir. Thank you so much.
Thank you, everyone.
I think next, if you, I know you all have a lot of questions to ask, and so that can be done during the lunch time. Okay, and over to anchors for further proceeding.
Dr. Vivek S. Agarwal, sir. Mr. Paras Nath Singh, sir. Mr. Hemant Bhatnagar, sir.
Thank you once again to all our speakers for sharing your expertise and enriching the session.
As we approach the conclusion of this session, I invite Dr. Varsha Tanu Ma'am, Associate Professor, IIHMR University, Jaipur, to propose a gratitude to our dignitaries and speakers.
Thank you, Aditi. On behalf of IIHMR University, it is my privilege to propose a heartfelt vote of thanks at the conclusion of this enriching session. As AI is recently also, you see that AI is the core of all the discussion, and recently we saw how AI Summit at New Delhi basically concluded with a message that real transformation can be achieved only when the technology is supplemented by access. And it is no more a framework, though now we have come to the execution stage. So with that, I would like to express our deep appreciation to the eminent speakers for their enlightening presentation. Your contributions have not only expanded our understanding of the evolving role of artificial intelligence and behavioral science in public health, but have also inspired us to think critically about their application in real-world community setting. The depth of the knowledge and practical perspectives shared today will be undoubtedly guide our future actions. Speakers, specifically a few takeaway points. Mr. Paras Nath Singh, Director Program, the Andhra Foundation. You spoke about, very nicely you showed your presentation and your intervention that how chatbot uses at grassroots level by AAA Anganwadi workers, A&M and ASHA workers under Andhra Foundation is happening. And how in the morning session we saw that how hyper-local contextualization is important in terms of technology use, and that's a true example, sir. Second eminent speaker, Dr. Ashwini Agrawal, not only a doctor, but a leader in true sense, and how you spoke about the paradigm shift, and it is no more just a talk of the framework, it is now execution at the core level, and more demand-side driven and outcome-oriented technology interventions are needed. Our third eminent speaker, Dr. Vivek Agrawal, founder, Center for Development Communication, showed us, guided us very interestingly that how environment, economics, and society leads to a real sustainable development and equitable healthcare is the key for reducing all kind of gaps. Our fourth and very interestingly, I just complimented him that I personally am a fan of the way Dr. Shetty speaks, as an orator, and I didn't know that officers of Narayana Health, although I mean, one officer I just heard, and he's equally good speaker. So, Mr. Hemant Bhatnagar, sir, Facility Director, Narayana Health, and very aptly you spoke that how AI uses at community health ecosystem, its implementation and its integration with the trust and human values can change the face of healthcare of the future generation, and paradigm shift is happening in true sense. And at the end, जो last concluding line, but वो हमारा दिल ले गई कि AI must amplify compassion. It's not a substitute to that. So thank you very much once again for being here and guiding our future healthcare professional. Thank you very much.
Thank you, ma'am, for your gracious words.
With this, we conclude track 1 of day 1.